Our next speaker for the hour is Dr. Edward Jouney. Dr. Jouney is an addiction psychiatrist and clinical assistant professor of psychiatry at the University of Michigan. He also served as director for addiction psychiatrist fellowship program. Dr. Jouney completed his general psychiatry residence and addiction psychiatrist fellowship at the University of Michigan, and he then joined the staff at Michigan Medicine in 2011. His clinical interests include managing addiction during pregnancy, treating licensed health care providers who struggle with substance use disorder. Dr. Jouney has provided many speeches in the area of addiction throughout the state of Michigan. He is actively involved in training of the medical students, residents, and fellows at the University of Michigan. So at this time, let's put our hands together for Dr. Edward Jouney.
So it's great to be here. Today we're going to be talking about diagnosing substance use disorders, specifically opiate use disorders. We're going to go over a case. Then I'm going to go over with you the DSM-5 criteria for diagnosing substance use disorders. Then we're going to go over some examples of how to conduct a good clinical assessment. The general theme that I want to convey to you is that diagnosing substance use disorders can be very difficult. Certainly you have cases that are very easy. You have somebody coming in reporting that they're injecting intravenous heroin, or they're using excessive amounts of their prescription opiates. Of course, those cases happen. But other cases are much more challenging, and that's what we're going to talk about today. I do not have any financial disclosures. So this is just a quick overview of what we're going to talk about. As I said, we're going to go over a case. Then we're going to go over the DSM-5 criteria. We're going to go over specifics for opiate use disorders. We're going to go over assessments. We're going to briefly talk about screening and assessment tools. Then we're going to talk about the interview. And then we're going to conclude. And of course, I'll take the time to answer any questions. So we're going to start off with the case. And what I'm going to do is, I don't like standing up here, so I'm going to kind of go to the ground level here, if that's okay. So this is a real case. Whenever I present cases at lectures, I always like to do real ones because it kind of makes it more real. So this is a 33-year-old male with a 10-year history of chronic back pain and is prescribed 90 milligrams of oxycodone and 2 milligrams of Xanax. The medications are prescribed by his primary care physician. He does have a psychiatric history. He has a history of depression, anxiety, PTSD, but he's not currently engaged in any psychiatric care, and right now his only healthcare provider is his primary care physician. He is frequently requesting early refills of both the Xanax as well as the oxycodone. He states that he does run out of these medications early, but he states that this is because he has a GI problem and he has recurrent vomiting. And taking the medicine triggers the vomiting episodes, and at times he actually regurgitates the pills before they've been swallowed. And he says he's had this since he was a child. You're concerned about possible addiction given the early refills. You talk to his wife, who works as a nurse, and after you obtain consent, she says she doesn't have any concerns, and she says her husband actually hates pills. I'm assuming you guys have heard this before, right? Yeah, okay. So his wife further states that her brother struggled with drug addiction, and she says, if my husband was addicted, I would know it, very forcefully. She also verified his report about he has this recurrent emesis and frequently regurgitates the medicines he swallows. A urine drug screen done in the office shows morphine and diazepam, which he is not prescribed. You do a prescription monitoring, so he says that, yes, of course I was prescribed those medicines because I dislocated my shoulder 4 days ago. What was I supposed to do? So we went to a local emergency room, and that's what the doctor gave him. It's not my fault. I went there, I was asking for help, and this is just what the doctor gave me, right? Okay. So you do a prescription monitoring report. I'm assuming you guys have prescription monitoring reports down here, right? I think that was previously mentioned in the previous talk. So you do a prescription monitoring report, and it shows that he did obtain morphine and Valium from a local ER provider that works at a local emergency room. You don't have the ER records, though. So you just have the prescription monitoring report that shows the morphine and the Valium. You're still concerned. Well, now you got this. Now he's getting prescriptions from another provider, even though it is, he says that there was a legitimate reason for it. You're still concerned, and now this is really expanding outside of your scope of practice, so you want to refer him to an addiction specialist, not because he needs treatment with addiction, but because you want clarification. And we get these consults all the time. Just because somebody comes in to see me doesn't mean they have a drug problem. It means that their primary care provider needs help. They need help diagnosing this. They don't know what's going on. So you're not saying he has an addiction. You're saying, you know what, I want help figuring this out. So they suggest to send him to an addiction specialist just as a consult. He becomes very angry, as does his wife, and they allege that you're being inappropriate, you're passing prejudice and judgment because I have chronic pain. They immediately request to be transferred to another physician in the practice, and they want to talk to your boss. Okay? So keep this case in mind, and we're going to come to this at the end of the talk, and we're going to kind of talk about some of the strategies that we can implement here. I'm assuming that what I'm bringing up here, this is familiar to the people in the audience. You can identify with a case similar to this? Okay. So questions, what we're going to talk about at the end is how do you confirm or rule out an opiate use disorder in this patient? Then we're going to talk about what do you do about the continued prescribing the oxycodone and the Xanax, and what would be the next steps. All right. So currently, what we're going to do is I'm going to go over the first topic is going to be DSM-5 basics. When we diagnose substance use disorders, or AKA drug addiction, that's currently defined by the DSM-5, which is the 5th edition of the Diagnostic and Statistical Manual that's published by the American Psychiatric Association. The word addiction has many unofficial meanings. It has a political meaning, it has a social meaning, and there's a medical definition. What we're going to be talking about today is the medical definition of what it is. Unfortunately, the word addiction is used pretty ubiquitously. It's used very casually, right? But I want to emphasize to you, it does have a specific medical meaning and medical definition, and that's what we want to talk about. So currently, within the DSM-5, which is again the official guideline for this, there are 10 separate classes of drugs that are identified. We have alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, stimulants, tobacco, and others that may not fall into that category. But there's officially 10, okay? The interesting thing about this is that I want to share with you is that these are not fully distinct. What I mean is that any of these drug classes, regardless of what drug class they're in, if they're taken in excess, they activate, at least in a vulnerable person, they activate the same reward mechanisms in the central nervous system. That's actually interesting because if you look at these drugs, and let me go back a slide, so they're pretty distinct. Alcohol is very different than a psychostimulant, but despite their differences pharmacologically and physically in the way they activate the same neuronal circuits in the central nervous system. And the other interesting thing is that the diagnostic criteria, pretty much for all of these substances, is they're almost identical. So despite the differences in character of these drugs, we have sedatives, we have stimulants, we have different physical characteristics to the drug, the diagnostic criteria for addiction are identical. That's quite interesting. Gambling is also in the DSM-5, all right? The interesting thing here, and I'm saying in the text underneath it, is that it's known to activate some of the same pathways. If we're getting a history from a family member, let's say a wife is coming into her primary care doctor's office and she's concerned about her husband, and she's saying, as a doctor, I don't know what's going on, he's doing poorly at work, his mood has changed, he's very irritable, there's large amounts of money missing from our checking account, he won't tell me where it is, he's being very evasive, he's having mood swings, he's irritable. Well, in my business, that can either be a cocaine addiction or it's gambling. They look identical. So it's interesting that when you're getting a history from somebody that is living with somebody with a gambling addiction, the behaviors they're expressing are almost identical to that of a substance use disorder. However, this is taken right out of the DSM-5, this is a text, and by the way, you all have access to my slides, so I'll make sure that I'll talk to the people that put on this conference here, and I would like to make these slides available to anyone who wants them, so don't feel you have to write anything down. This is taken right out of the DSM-5, okay, so this, copy and pasted this, that's why it's in quotations. What this is saying here is that there are other behavioral addictions. So there include exercise addiction, internet addiction, but these do not meet the scientific threshold for a true addiction. So while we recognize that they're there, these behavioral addictions are currently not classified in the DSM-5. The only behavioral addiction that is currently categorized in the DSM-5 is gambling addiction. So what does the DSM-5 do? So it basically separates substance use problems into two categories. There's substance use disorders and there's substance-induced disorders. So those are the only two categories, so it's relatively simple. What we're going to be talking about today are the substance use disorders. Substance use disorder means addiction. They're synonymous, they're identical, they mean exactly the same thing. But the people who architect and who write the DSM-5 did not want to use the word addiction because the word addiction for some people can be very pejorative, stigmatizing, so instead of that, they decided to call it a substance use disorder. And that's what we're going to be spending the majority of time on, is talking about that. The substance-induced disorders include intoxication, withdrawal, and then you have the substance-induced psychiatric conditions such as substance-induced depression, anxiety, psychosis, and so on and so forth. Substance-induced disorders do not mean addiction. You could have a you could have an alcohol withdrawal, you can have an alcohol intoxication. It doesn't mean that you're addicted to alcohol, okay? And if there's questions, we'll certainly elaborate on that a little bit later. So substance use disorder. So again, the first paragraph here is taken right out of the DSM-5, and I'm going to read this verbatim because it's important. So this is the core concept of substance use disorders. And again, this is addiction. So the essential feature of a substance use disorder is a cluster of cognitive, behavioral, and physiological symptoms indicating that the individual continues using the substance despite significant substance-related problems. That's the core of it, okay? And these include what we see in people that struggle with this problem is we see changes in the brain that persist beyond detoxification. And that's important from a treatment perspective because if you're just referring somebody to inpatient detox without instituting any other aftercare, their outcomes are very bad. So whenever we refer somebody to detox, we want to ensure that we have something structured beyond that. Sometimes it's a long-term residential program, sometimes it's an IOP or a PHP, but you have to do something. This is especially true when we talk about opiate use disorders. If you have somebody that is utilizing opiates, whether they're using heroin, prescription medications, whatever, just simply detoxing them, unfortunately, results in very poor outcomes. They need long-lasting care because addiction is a lifelong illness for some people. It is a chronic, relapsing, remitting disease. And one thing that I do want to say that is not on the slides, but I think it's important to talk about, I think it's important that collectively the health community, and I'm not just saying mental health or those that work in addiction, I'm saying health community globally, I think we need to start addressing and identifying the stigma and prejudice that is associated with this illness. And prejudice and discriminatory attitudes that are implemented by many that work in the healthcare profession. It's really bad, and I've had the opportunity to talk to some of you that work down here in Louisiana, and the stories I've heard is worse than what we're seeing up north. Physicians refusing to see patients. There was a comment about that earlier. I don't know the details of that, but these are not bad people. They have a bad illness. And it would be fantastic if, the individuals that work in medical education, those that work in policy, in addition to holding events where we're talking about some of the technicalities about substance use disorders, some of the treatment modalities, those are fantastic. But I think it's time we need to start talking about the social aspects of it and talking about the discriminatory and prejudicial practices that are actually going on because it's pretty bad and it's really uncalled for. I mean, in my opinion, I don't typically editorialize during presentations, but honestly, if you're having some kind of an adverse reaction to working with these patients, maybe you shouldn't work in healthcare. Because people with substance use disorders represent probably 15% of the population. And if you're having that kind of attitude towards 1 in 10 patients that walks into your office, maybe this isn't the area for you, okay? So, we're going into healthcare because we want to help people, and people should be treated with dignity and respect. They should not be marginalized. So that's my editorial. Moving on. This is interesting. So substance use disorders can be applied to all classes of drugs except caffeine. Caffeine in the DSM-5, I believe there's a caffeine intoxication syndrome, there's likely a caffeine withdrawal syndrome, but there is not caffeine addiction. There is not a caffeine use disorder. So honestly, if we had time, I would love to spend the whole hour talking about this, because I'll have half of the room that wants to argue it and the other half who has different types of opinions on it. But it's interesting when I bring this up, the conversation it stimulates is fascinating. Caffeine is typically not an addiction, and people ask, well, why? Well, I'm addicted to caffeine. Well, you're probably not. And I go through just these little stories. So yes, I do think you're addicted to caffeine. Let's just say you're married, and you tell your wife, you say, honey, what is a big grocery store you guys have down here? What is, I'm sorry? Rookshire's? Kroger? Okay, we'll say Kroger, that's easy to say. So let's say you tell your wife, you say, I'm gonna go to Kroger and I'm gonna get a carton of milk. We're out of milk, I need the 2% milk, whatever. But instead of going to Kroger, you go to Starbucks. And you lie, so you drive to Starbucks, you make sure you put on your sunglasses so nobody sees you driving to Starbucks, and you pick up your mocha double shot latte, and then you drive behind the Kroger dock, behind the store where the trucks pull in, and you drink your latte in privacy with the windows closed. And then after you're done drinking the latte, then you take the cup and you throw it in the dumpster to ensure that there's no trace that you actually had the latte. So if you're engaged in behaviors like that, then yes, you may have a substance use problem. But the point I'm making is that coffee typically doesn't elicit these types of behaviors. And then people can say, well, that's because it's more socially acceptable. No, really not. Because the reality is, let's say if we outlawed coffee, okay, I think the majority of people would be upset, they would be angered, but it typically wouldn't go beyond that. And again, I know there's a lot of differences of opinions on that, but we'll just kind of leave it there. But anyway, the point is that this is not identified in the DSM-5. So when we're looking at substance use disorders, what I'm going to do is I'm going to first talk broadly about substance use disorders, then we're going to talk more specifically about opiate use disorders. So again, the criteria are almost identical for other substances. So the DSM-5 breaks this down into 4 groups of categories. We have the impaired control, the social impairment, the risky use, and the pharmacological criteria. So the DSM-5 has 11 criteria for opiate use disorders, and they're broken down into these categories. I'm going to go through them each individually. So this is the category, this is the criteria 1 through 4. So the first criteria, again, this is with respect to impaired control. The individual may take the substances for longer amounts of time, over longer periods of time than was originally intended. Number 2, the individual may express a persistent desire to cut down or regulate substance use. The third one is the individual may spend a great deal of time getting the substance, using the substance, or recovering from the substance. And criteria 4 is craving. The one thing I want to point out to you early on as we review these criteria is that one thing you will typically not see here is quantity of use and frequency of use. And that's very interesting. The DSM-5, when we're diagnosing addiction or substance use disorders, the focus is on behavior. It's not about quantity and frequency, although those are important. The emphasis is on the emphasis is on behavior, not just behavior, but recurring behavior. So when we're diagnosing this problem, I'm looking at recurring behavior. Of course, I'm concerned about how much you're drinking, I'm concerned about how often you're drinking, but I'm more concerned about the resulting behaviors and your continued engagement in those behaviors. That's what we're looking for. Social impairment, this is criteria 5 through 7. Recurrent substance use may result in failure to fulfill major work or school obligations. This is a big one that we see. I work with a lot of healthcare providers. That's probably about 50% of my practice. And this is a huge thing that we see. We see individuals that are unable to practice their profession, whether it's nursing or medicine. They're unable to carry out that work because of their substance problem. We also see this a lot with teachers as well as with lawyers. And really, it affects every profession, but usually the ones in which a state license is involved tends to have more consequences associated with it. Number 6, individual may continue substance use despite having a recurring social interpersonal problem that's caused by the substance. And criteria 7 is social, occupational, and recreational activities are given up or reduced because of the substance use. So we have now criteria 8 and 9. This is now risky use, and but this is typically is that you're using it despite physical hazards. So criteria number 8 is that you continue to engage in recurrent substance use in situations which is physically hazardous. That's typically individuals that are driving under the influence of alcohol or driving under the influence of any other substance. It's not just driving, but engaging in any activity in which the utilization of the substance puts you at risk. And criteria 9 is that you continue to use the substance despite knowing that it's causing you harm. So the last two, number 10 and 11, I want to spend a little bit of time on because this causes significant confusion. The last two criteria for opiate use disorders in the DSM-5 are tolerance and withdrawal. These are easily defined pharmacologically. Tolerance basically means that you need more of the substance to attain the same effect. Withdrawal means that once the substance is stopped, your body's going to get mad at you. You're going to start to exhibit significant physical and psychological symptoms because of the withdrawal of the drug. These do not in themselves mean that you have a substance use disorder. The occurrence of tolerance and withdrawal are normal physiological properties that happen to anybody. It's the way your body is engineered. It has nothing to do with behavior. Now, do people with addiction have these? Of course they do sometimes. But if you simply have somebody with tolerance and withdrawal, it doesn't mean they have a substance use disorder. And this has caused a lot of confusion within the healthcare community, and many people have had their medical charts mischaracterized, and clinicians have put diagnoses of opiate use disorder or opiate dependence just because they're exhibiting one of these two phenomena. Okay, this is not a substance use disorder. Okay. And as we're seeing here, and again, this is taken in quotes, this was taken out of the DSM-5, the appearance of normal expected pharmacological tolerance and withdrawal during the course of medical treatment has been known to lead to erroneous diagnosis of addiction. Absolutely. And we have the last one here that I have bolded. Individuals whose symptoms are tolerance and withdrawal that occur as a result of appropriate medical treatment should not receive the diagnosis of addiction solely based on those symptoms. If you have somebody that is a chronic cancer patient that's currently prescribed high-dose oxycodone, I can tell you if you stop that oxycodone, they're going to have withdrawal. I guarantee you if they've been on the medication a long time, they've exhibited some degree of tolerance. Does that mean they have an addiction? No. This is just a normal course of human physiology. It happens. It happens with benzodiazepines. It happens with opiates. Typically, any medicine that interacts in some fashion with either the central nervous system or the cardiovascular system, you're going to see tolerance or withdrawal. It happens with beta blockers. It happens to some extent with antidepressants. Okay, it doesn't mean you have a substance use problem. You do have a substance use problem if this is an occurrence with other stuff. So if you have tolerance and withdrawal and you're engaging the other recurrent, aberrant, or dangerous behaviors, then yes, you certainly do have a substance use disorder. We do have specifiers. So when we're categorizing this, if you have 2 or 3 of the criteria that I just mentioned, it's mild. 4 or 5 is moderate. 6 or more severe. And then we can specify in early remission, sustained remission, on maintenance therapy, or in a controlled environment. And we're going to elaborate on what those are in a moment, like right now. So this is specific for opiate use disorders. So in opiate use disorders in remission, if they don't meet any of the criteria for at least 3 months but less than 12 months, they can have craving. They can still have craving, but they can't have any of the other 10 criteria. So in that case, if it's been more than 3 but less than 12, the diagnosis is opiate use disorder in early remission. If they don't meet any of the criteria except for craving for 12 months or longer, then they're in sustained remission. The sustained remission specifier is important because, at least in my opinion, it emphasizes the clinical point that opiate use disorders are chronic conditions and often involve cycles of relapse and remission, as I've talked about. Let's say you work in primary care and somebody is just establishing, they're just establishing care in your office, and you're taking a history from them, and you find out that 10 years ago they had a problem with prescribed opiates, and they say, I've been clean for 10 years. You still have to pay attention to that clinically. And they still have a diagnosis of an opiate use disorder, but it is in sustained remission. The reason why that's important to notate in the chart is because you need to check on them. Just because somebody has 10 years of sobriety doesn't mean that they're not still vulnerable. And oftentimes this is missed, and it's important to realize we've had people in our clinic that have relapsed after 10 years. We've had people that have relapsed after 20 years. And unfortunately, it happens. You do have some individuals that have a stint of a substance use disorder. They may experience, a 6-month history of opiate addiction in their 20s. That's it. It was that time. It's done and gone, and it never comes back again. There's cases that are certainly out there, but that's not the majority. The majority of people are going to have lifelong vulnerability. And so you want to ensure that as you're taking care of these people in a primary care setting, that you're actively assessing this. And it's just simple as, I know you're coming in for your yearly physical. Last time I saw you had 10 years sober. How are things going? Okay, and how are you maintaining your sobriety? Some people utilize community support meetings, such as NA or AA. Other people do other types of things. If they're not doing anything, I would question that a little bit and ask them if they need any help. Is there anything I can do to help in your recovery? So on maintenance therapy, as the gentleman spoke earlier, we have medicines, methadone, buprenorphine, and naltrexone. So if they're on any of these medicines, then they are considered to be on maintenance therapy. And again, I'm going to digress a little bit, but as we talked about some of the unfortunate attitudes that healthcare has with regard to maintenance therapy, that is especially an issue with respect to the judicial system in some areas, as well as law enforcement. We had one mother, I work with pregnant women often, and we had a mom that was on methadone maintenance treatment. She had just delivered her baby, and she was on methadone maintenance treatment, and she was on probation. She was on probation for a drug-related charge. This is somebody that was doing amazingly in treatment. She was doing very well. She got her life back together, taking care of her family. She was doing good. Her probation officer said that if she did not stop the methadone, that she would violate her and she would send her to jail if she did not stop the methadone. I tried talking to the probation officer. That didn't go over well. I said, this is an evidence-based treatment. She is not seeking this out. She is just abiding by prescribed recommendations. And when I said this is an evidence-based treatment, she said, we don't consider it to be. So unfortunately, you have these attitudes, and that's what I think that we need to address. We need to educate people, and that's the next front we need to combat. I think right now we're combating the crisis with regard to overprescribing, the misconceptions as opiates being this panacea for chronic pain. I think we're addressing that, but now we have to get, we got to get our shoes in the mud and we start to address some of the prejudicial attitudes. Okay. So some clinical points. So now we're going to talk more about. That was just a general background about diagnosing opiate use disorders and substance use disorders in general. What we're going to do now is start to emphasize on opiate use disorders specifically. Some of the key points, again, I talked about this in the first 2 minutes. This can be challenging to diagnose, okay? Some cases may take weeks or months to rule out an opiate addiction, especially in individuals that are prescribed long-term opiate analgesics. There's something that happens in addiction that I call sophistication. You won't find it in the medical literature. It's something I just made up. But what happens with people that are struggling with substance use disorders over the long term, they develop this sophistication. And what the sophistication is, they become very well versed in interacting with the healthcare community. They become masters of controlling the physician or the clinician-patient interview, okay? And this isn't a skill. This is actually an aberrancy. It is actually a cognitive adaptation that is from the substance use disorder. And this gets misconceived as people being manipulative or they're lying. Those are very pejorative terms, but this is actually, in my opinion, these are psychological sequelae to the illness. And once they get in treatment, it goes away. But because of these adaptations, people can be very well versed in fooling you. So that's something important to know, because it's really inconceivable to think that we're going to have patients coming to our office. I'm going to ask them those 11 questions that I went over with you, and I'm going to say, well, you answered 5 of them right, so you have a moderate opiate use disorder. It doesn't work out that way. If you go through there and you ask them, the questions in DSM-5, they're going to answer no to everything, especially if they're trying to conceal a problem from you. Okay? So as I said here, some cases may take weeks or months to rule out a diagnosis. That is so true. We have people coming back on a regular basis just so we can get a handle on what's going on. And you really should avoid notating in the medical record they have an opiate addiction unless you're 100% sure. If you're not sure what's going on, do not put it in their medical record because of, as I mentioned, Unfortunately, some of the negative attitudes we have towards this illness, if you put that in their medical record, they may be treated in an unsavory way by future healthcare providers because that's documented in their record. So given that, how are we going to diagnose this? So there are many ways of diagnosing this problem. So when we're presented with a case, we take a comprehensive approach and we implement multiple layers to this assessment. So we obviously do the patient interview. We do a drug screen. We do a standard immunoassay, which is just the positive, negative, either it's there or it's not. Please note that the standard immunoassay, which is the drug screen that most people are familiar with, this is prone to false positives and false negatives. So when you see a positive on that screen, that is a presumptive positive, meaning that maybe it's there, but maybe it's not, okay, because of the false positive rate. We can get more sophisticated drug testing, which confirms what we saw in the immunoassay. That's called GCMS. That's a sophisticated form of testing that not all healthcare systems or laboratories do. We can do special testing, such as hair analysis. That can be expensive, and again, it may not be available in all areas, but again, that's just another sophisticated form of testing that we can do. We review the prescription monitoring report, we do a physical exam, and we may need to get collateral sources of information. You may say, oh my gosh, this sounds like a forensic assessment. Well, sometimes it is. Sometimes we really have to kind of peel back the layers of the onion, but the art of this is doing it in a manner that is respectful to the patient and they're still being treated with a lot of dignity as we're kind of doing this. This is not a gotcha game. This is not, oh, you're lying to me and I'm gonna prove it. This is, there's something going on with you. I don't know what it is, but we're gonna work together and I wanna find out how I can help you. That's the approach you have to take. This is a fantastic resource. Again, there are assessment tools. And you can have this link when you get the slides. This is from NIDA, and what it does is there are brief assessment and screening tools that are geared towards primary care that can be implemented in your office in a very quick manner. So you don't have to sit down and conduct a 90-minute interview with your patient, because I understand a lot of us that work in practice, you're on significant time constraints. I mean, I work in mental health, and I'm fortunate to have a lengthy time interval with my patients. Not everyone has that. And I understand that some people, you may not have more than 10 or 15 minutes. And so sometimes it makes, some of the suggestions I'm going to be, giving you today, you may not be able to do that in your office just because of the time limitations you have. So this is from NIDA, and this shows a whole wealth of screening tools. And these, keep in mind, these do not identify addiction. What they do is they identify at-risk patients. So what I'm going to be showing you here, these do not diagnose a substance use disorder, but they will help you as a healthcare provider identify people that are at risk. So these are some of the screening tools. So the screening tools meaning, is there something going on or is there not? So the screening and brief intervention is something, or the ESPER, this is something that is widely used in primary care. I'm not going to go through these. You guys can see them here, and you can take the link to the website, and it'll show you them. You can download them, and you can implement them in your office if you don't have those already. These are some of the assessment tools, and again, these are accessible online, and they're very easy to administer. The problem with these, well, the advantages is that they're evidence-based, meaning these have been studied. Okay, so they've been validated, they've been studied, they're very easy to administer, and you're able to identify at-risk patients. But what are the downsides? The downsides is that they rely very heavily, if not entirely, on the patient self-report. So you're essentially really, this is just based on what the patient is willing to share with you. And sometimes, depending on how much the addiction has progressed, they may not be willing to share a lot with their healthcare providers. So it doesn't make it very useful in that respect. And like I said before, it's less likely to identify patients who are dealing with a substance use problem who are actively trying to conceal the problem from you. But nonetheless, it's a great tool to use in primary care because it can help you identify those patients that are at risk. Okay, now we're going to get into the interview techniques. So this is the part that I'd like to spend the most time on because I think that this is the most important. So when we're conducting an assessment with the patient, so let me just kind of set the mood here. So we have somebody coming in, and they're coming in, let's say, because their spouse wanted them to come in. Or they need, I don't know, somebody from work raised a concern, and they said, we want you to go see your doctor. Basically, what I'm saying is this. They're not coming to you because they want to. Okay, they're not coming to you saying, Dr. Smith, thank you for seeing me. I've been wanting to schedule this appointment for a long time now. I've been using intravenous heroin for the last 3 months, and I really need your help. Please tell me what to do. I'm ready. Here's my insurance card. Let's get started. Okay, it doesn't happen that way. So let's set the stage. This is somebody who is coming to you but reluctantly. And they're kind of sitting there with their arms folded, and they have to be there, but they really don't want to. You do not want to start that assessment by asking them, well, so-and-so referred you to me because they're concerned about your utilization of pain meds. What do you think? You don't want to start off by asking that question. What you want to do is that you want to make them relaxed. You want to establish a rapport, and you want to create an environment that is going to make the admission of use, if they're using, it's going to make it less intimidating. So what do? This is what I do. I'm going to share with you what I do, and you can decide whether or not that this is going to be helpful to you. I usually start off by getting the social history, because the social history is typically benign and non-judgmental questions that help the patient relax. And this allows you to learn volumes about the patient even before you ask them about their substance use. Let me tell you how this goes. So somebody's in there, arms folded, doesn't want to be there, giving me the stare, doesn't want to do anything but get out. So what I say is, thank you for coming in. I always do that. I thank them for taking the time to come in. It's a nice courteous gesture, and it's an initial establishment of rapport. I say, thank you for coming in. I appreciate you taking your time out of the day. What I'd like to do is get to know you a little bit and see if there's anything I can provide that would be helpful to you. I don't even mention substance use. I say, I'd just like to get to know you a little bit so I can see if I can be helpful. I'm identifying myself as a treating provider. And the first question I ask them is where they live. Where do you live? You can't get any more non-judgmental or benign than that. Where do you live? And then I go a step further. Who are you currently living with? How are things going at home? Are you currently employed? What do you do? How are things going at work? What's the highest level of education that you have? Okay. Then I ask a little bit more details. I ask them, do you have anything going through the legal system right now? That's important. Okay. Then if they say yes, and I want to know what it is, I don't ask them what it is, I ask permission. I say, would you feel comfortable sharing with me what's going on? Or is it okay if I ask you a little bit more about that? It's just a small gesture, but it really speaks volumes. And again, you're making them relaxed, you're creating a non-intimidating environment. Once I got that, you will be surprised, just on those few questions, what a voluminous amount of information that you have just obtained. The next thing that I ask them is, I ask them about their family history. But what's really important is I ask them about home and work. And it's so important to know who they're living with, if they're in a relationship, and how that relationship is going. If they're married, I ask them, how are things going? If I say, are you currently married? Yes, I am. How are things going in the marriage? Just open-ended, okay? These individuals also have a very high prevalence of trauma. Some of them do, especially when we're working with pregnant women that have opiate use disorders. There's a very high occurrence of intimate partner violence in that population, and assessing a trauma history is also very paramount. And again, this is done in a very gentle, non-judgmental way. What I ask about when I'm getting a trauma history, I ask 3 questions. The first question is, where did you grow up? The second question is, what was it like growing up for you? So again, a very open-ended question. If they see it was horrible, then the next question is what? It's just one word. Why? Okay? Again, and they will open up. Sometimes they will, sometimes they won't. But again, you see how just very simple, open-ended, short questions can provide you with very high-yield information. So this is the way that I do it, okay? And I would encourage you to take this approach because it's extremely helpful. Clinical points, this is just a summary that we just talked about. You want to be open-ended. You want to avoid using judgmental words such as abuse or addict, meaning asking them, have you ever abused your pain medicine? You're probably not going to get a very high-yield answer with that type of a question. Again, as I talked about, I said this about 3 times already, but you want to create an environment that makes the admission of use less intimidating. Again, make the patient feel relaxed. You want to emphasize your role as a treating provider. And this is also important. Avoid writing stuff down or staring at a clipboard. I don't know why, but people in healthcare, they have this relationship with their clipboard. It's with them wherever they go, and they stare at it all the time. I understand it's important, but when you're in an assessment like that, sometimes it's best to not write anything down. Trust me, you're going to remember what they tell you. But especially if you're working with somebody that is feeling very intimidated, somebody that is very anxious, it may be a good idea just to put the paper down. And the other thing that I do is I put myself at their level. If they're sitting down, I sit down. I never stand over somebody taking this type of a history. I always sit down with them and create more of a conversation type of an environment. Okay, so you want to normalize things. So if you're really sensing that after you get the social history that this is really kind of snowballing into somebody has a problem, you want to say, I work with patients that struggle with this problem, and with help they get better. So what you're doing is you're normalizing it. You're not kind of identifying this as like a bad thing. You're saying, hey, this happens and we can help you. These are some questions that I have. So these are examples. You guys can, please feel free to use these in your practice if you find them helpful. So does the use of pain medicines ever provide you with more than just pain relief? Why is that important? It's important because many people that start to misuse prescription opiates are usually attempting to mitigate or self-medicate against symptoms of trauma. Okay, not in all cases, but in most. So you have somebody that was either physically or sexually mistreated. They've developed significant PTSD spectrum symptoms. Because the nature of the trauma, they become very reluctant to disclose this to anybody. So they develop these underlying symptoms of severe anxiety and significant emotional discomfort that they can't talk to anybody about. In some instances, these trauma symptoms start to they can convert into physical symptoms. Many people develop chronic pain syndromes with no identifiable physical etiology. They go to their primary care provider. They get put on traditional medicines that have no help because, again, the origin of the pain is not a physical manifestation. But they escalate up to opiates. So they get placed on Vicodin for the first time. What's going to happen? Well, that Vicodin, it's not necessarily going to provide them with a pain relief effect. What it's going to do is it's going to act as a very potent antidepressant, an immediate antidepressant that works in about 2 hours. And it's also going to provide some anxiolytic relief or some anti-anxiety effect as well. So for the first time in 20 years, they actually feel better. And because they may have an underlying vulnerability towards drug addiction, this is going to create reinforcement, it's going to create reward, and they're going to engage in compulsive use. So I often ask the patients, like the first question here, does utilizing these drugs ever do more for you than just provide a pain relief effect? Does it help with your anxiety? Does it help with your depression? Again, this doesn't diagnose addiction, but it helps to identify an at-risk patient. Another narrative you can say is, again, this is in quotes, it's quite common for people who use opiates to feel some emotional relief from taking these medicines. I know you struggle from depression and anxiety, and I was wondering if your pain meds ever help alleviate those symptoms. The third one here is that have you been in situations when you've taken more than you wanted to? It's important to note the way this is worded. I'm not asking them, have you taken more than you should have? I'm asking them, have you taken more than you wanted to? Again, what we're doing is I'm not blaming the patient. Have you ever taken more than you wanted to? So sometimes even just shifting the words can be very helpful. Do these medications ever make you do things you ordinarily would not want to do? The last one here is, once a patient starts taking a higher dosage, it becomes very difficult for them to come back down on a lower dose or stop. Has this ever happened to you? So asking these questions is not going to give you 100% reliability and everyone's going to tell you the truth. But what it is going to do, it's going to increase the yield of your answers. Once you ask these questions this manner, it's more likely that somebody is going to be honest with you. And when you're doing these assessments, that's what you want to do, is you want to establish an environment of trust. Now, not everybody's going to be trustful, but nonetheless, approaching this in this manner is going to make it a little bit more easier. Some more questions. Have you ever obtained opiates from anyone else other than a doctor? When we're assessing opiate use disorders, it is very common for people to obtain medicines from illicit sources. How do you ask that in a clinical situation? You don't ask them, are you getting your medicines from a dealer? Are you stealing medicines? Of course they're going to answer no. I mean, some people will be honest with you and they'll tell you, but again, we're talking about the person there, arms folded, angry, doesn't want to talk to you. Going in there and asking them, do you ever steal meds? Are you buying them from the dealer down the street? So sometimes asking them in this way, again, have you ever obtained medicines from anyone other than a doctor? Okay. And if they say yes, again, ask permission. Would you feel comfortable sharing that with me? I'm, interested to know. And if they say no, then you stop. That's the other thing too. If somebody says they're not willing to answer a question, Okay, you're not an attorney, this isn't a courtroom. You stop, okay? There's nothing worse than, than really antagonizing somebody. If they don't want to answer the question, then you don't answer it. And if I ask somebody, is it okay if I ask? They say, well, I would really not talk about it. I say, that's fine, we're gonna move on, okay? So, and a follow-up question is that, gosh, I know that can be quite expensive. I know my patients who are buying oxycodone, they're spending as much as $40 a tablet. Has this affected you financially? And I'm not asking that because I'm being voyeuristic. I'm expressing this because I'm caring. I'm saying, hey, how are you doing financially? This must be really rough on you. Some of my patients can spend $2,000, $3,000 a month. Are you doing okay? Okay, again, putting myself in the role of a healthcare provider. The second one here, have the opiates ever made you feel foggy or less alert to the point where you're not as sharp as you want to be? That's very much better than saying, do the opiates ever impair you? Okay. Asking in this way is a little less judgmental, and it can give you a good answer. Because if you notice the way it's worded here at the end, to the point where they make you less sharp, oh, I'm sorry, there's a typo here. It should be less sharper than you want to be. Okay? Has this ever put you in a situation that you didn't want to be in? So I think you get the theme of the questions. What we're doing here is when we're asking these questions, I'm putting the patient in the role of the victim. I'm saying, are these medicines doing bad things to you? That's very different than saying, are you doing any bad things to the medicines? Which unfortunately is the way that some healthcare providers ask these questions. They ask, do you abuse opiates? To me, that means they're taking a hammer and they're beating their bottle, okay? You do not want to ask questions in that manner. It's best to reframe it in this type of lingo because it makes it easier for the patient to understand and easier for them to answer. And the other one here under that is, has the effects of opiates ever placed you in danger? And the last one here, has opiates ever harmed you, or do you feel that they have the potential to do so? And again, these are very high-yield questions when you're making the assessment. We're going to talk now and go over the PDMP, which is a prescription drug monitoring program. These are implemented in most states. The ones we have in the state of Michigan is known as MAPS, the Michigan Automated Prescription System. The majority of states have them, I think with the exception, I think there's one state that doesn't, but most states have it. I don't know how it's set up down here in Louisiana, but in Michigan we have the drug name, we have the date the prescription was written, the fill date, the name of the provider, and the name of the pharmacy. And I think the method of payment is also there. Do you guys have the similar data here? Okay. These are not, in some instances they're very easy to read, but don't be fooled. In some instances they are exceptionally complex. And it's not uncommon for me to spend 2 or 3 hours dissecting one of these reports. You can't just look at it and say, oh, okay. Sometimes there's hidden things in here that you want to pay attention to. It's often important to really count the days between the prescription refills. And people often will notice that there's 4 prescribers on the report. Oh my gosh, there's 4 prescribers. You're using 4 different doctors to give your oxycodone. What they don't realize is those prescriptions are coming from the exact same office. Because physicians or who's ever prescribed, whether it's an MP or a PA, they take days off. And so you have other providers that cover for those people when the day the prescription needs to be refilled. So I don't look at the name, I look at the address, because in our reports, the address of the provider is there. So if I see there's 6 physicians, but they're all coming from 104 Market Street, okay, I know that this is the same office, they're not engaged in any erroneous types of behaviors. But if you see multiple different addresses, that's when you need to start asking questions. You also want to look up the clinician's specialty. I just don't look at the doctor's name. I want to know what kind of doctor is this. You obtained hydrocodone from who? Was it a dentist? Was it an allergist? I had a patient one time that came in and said that she's on Xanax, and she said, I need to be on Xanax because I just went to my doctor last week, and he said I needed to be on it. I said, who was a doctor? That was my allergist. I said, okay. I said, I really respect your allergist, but I don't think he should be making judgments about your mental health. Just like I'm not going to be making judgments about your allergies. Okay, that's not my scope of practice. This isn't his scope of practice. But oftentimes, again, these are types of These are behaviors that are typically implemented by the patient in order to get you to write the prescription. Because I'm sure if I talked to her allergist, it probably didn't go down that way. I'm sure he or she would give me a completely different story. But nonetheless, you want to look at the specialty. You want to look at where does this, what type of work does this person do? And for an example is if you see multiple prescriptions from Valium that are coming from a dentist. Okay, now I understand if somebody's coming in for a dental procedure, they may need a couple milligrams of Valium to help them relax. But if I see a dentist that's writing for 90 Valium a month, like every month, okay, something's going on there, and I need to ask questions. Again, I'm not passing judgment. I'm not making a conclusion. I want to ask questions. And I'll ask her very simply, why is your dentist prescribing you Xanax? Okay, and I may need to reach out to the dentist. Okay, so we're gonna go here, and we're gonna go back to the case. So you guys, first of all, were there any questions up to this point before we go back to the case that we initially presented? No? Okay. So we're gonna go back to the case here. So in the case that we just presented, how can you confirm or rule out the presence of an opiate use disorder in this patient? So if I can just backtrack a little bit, this was an individual who you were prescribing oxycodone and Xanax to. He's asking for early refills because of a GI problem, because he's recurrently vomiting up his medicines. His wife validated the history. You got collateral sources from her. He got a prescription of morphine and Xanax from the emergency department because of a dislocated shoulder. You wanted to get a consultation from somebody that works in substance use disorders, but he got very angry and said they wanted to be transferred to someone else within the practice. So does anyone have any ideas on what you can do in order to verify or to confirm your suspicion that this person is struggling with a substance use problem? And by the way, the answers don't have to be right. This is just meant to kind of get to get the neurons firing. Okay, so we can check the PDMP again. I think there was a comment here. I'm sorry, I'm having trouble hearing you. Okay, that's a good point. So, were the medicines prescribed when he went to the emergency department? Was that prescribed by the same physician, or were they prescribed by multiple providers? That's also a very good point. Does anyone else have any ideas on what we can do to help this person or identify if there's something going on? Absolutely. Did everyone hear that? So very good. So what the gentleman over here said is, let's look at his function, meaning that absolutely, let's look at how he's functioning at home, how he's functioning at work. Absolutely, that is so important. Because in very few cases, if somebody is struggling with an opiate problem, there's going to be detriment somewhere. Okay? So yes, I would entirely agree with you. But again, as we talked about, it needs to be done. You don't want to convey this in an I gotcha manner or like in a pejorative manner. It has to be very open-ended. Now, sometimes those interviews go well. Let's be honest, sometimes they don't. The other thing that I would recommend is talking to having his wife come in separately. And I know this can be time-consuming. Sometimes it's difficult to do in a busy clinical practice. But the phone calls that were conducted with the wife were conducted over the phone. And I often had the suspicion is that as I was talking to her, I think somebody was sitting next to her. And I think it was the patient. So another thing to do is to bring her in separately. And again, this can be difficult. And the way it would be done is this. I'll call her up to say, hey, hi, how are you? As you know, I'm managing your husband's care. Just some things I'd like to talk with you about. I asked his permission. He said it's fine that I speak with you. I was wondering if you can take maybe 15 minutes after work, come in, and maybe me and you can talk for a little bit. I just want to make sure I'm doing everything I can to help him. Okay, and then bring her in personally. Because something magical happens about a personal assessment when you're sitting across from someone. That's something I can offer. It doesn't always work out. People often don't want to spend the time and to come in, and especially if they're angry at you. It doesn't work out very well that way. I offered that to her, and she didn't want to come in. She wasn't pleased with the way that her husband's care was being managed because I had suggested she go and talk to a substance use person. The other thing that was there that I put on the test is to get a hair test. Because what a hair test will tell you is a hair test will show the substances the person has been using over a 90-day time frame. Now, again, oftentimes this is not available in certain geographical areas. It can be very expensive. and often it is done in forensic cases. The way that I conveyed it to the patient was that, hey, listen, this is what's going on. I just laid it out. I said, we're prescribing you these meds, you're going to other emergency departments, you're getting refills. I appreciate what you're telling me. I know you're telling me that nothing bad's going on, but listen, I have to do my job. Okay, and it's not professional of me just to take your word for it and just to look the other way. You watch the news, you see what's going on. I need to do my job as a healthcare provider. I need to rule out that nothing's going on. So this is what's happening. I appreciate what you're telling me, but I would like to get this test just to ensure that you're doing okay, because I'm worried about you. Okay? Yes?
Was there any documentation of his GI disorder?
No. Well, what he said, and again, that's a very good point. So the question up front is, was there any documentation of his GI disorder? And no, there wasn't. And I asked him that. I asked him, what's going on with this? You're having recurrent nausea and vomiting. Tell me what's happened. And what he said is that he went to his primary care doctor. His primary care doctor put him on Prilosec and wanted to do an upper GI, but he never went through with it. So, and the other thing I did is that I said, well, you're having recurring nausea and vomiting that's really affecting your pain meds. I work at a major healthcare center. I said, let's get you seen by GI. I said, this is a problem. So I called our GI clinic, and usually it's like a 3 or 4 month wait. And I called the GI clinic with him sitting there in the office. And I said, hi, I'm calling from psychiatry. I have an individual here with recurrent nausea and vomiting. He can't take his medicines. He hasn't been worked up. I'd like to get him in. And she said, this is true. She said the fellow had a cancellation tomorrow. And she said, we can get him tomorrow at 11. And I asked him, I said, well, can you come in tomorrow at 11? And he said, sure. But guess what happened? Wow, that was collective. Yes, he no-showed. He basically no-showed the appointment. So what I did was just to kind of summarize. What I did was I offered to meet with his wife privately. She declined that. I met with him again, not in a mean way, but I just said, hey, I'm working here as your psychiatrist. I need to get this stuff. Let's help me rule out nothing's going on. He did not want to do the hair test. To make a long story short, what ended up happening is that he ended up going into treatment. I don't know the details of it, but I got a note from his primary. I sent a note to his PCP, and I just said, hey, I'm just found, I haven't seen him. Can you tell me what happened? And he said that he was in treatment, but I don't know the details of how that happened. What my guess is that I think with, something must have happened within the home environment. So I wish I had a better kind of story to wrap it up, but the good news is that he did ended up going to treatment. So my suspicions were correct. There was something going on. Exactly how he wound up in treatment is a detail that I need to fill in. Yes?
How often do you see where the person is actually coming in and not the one that takes the drugs, but they're actually coming to get someone?
We see that often. So for those of you that didn't hear the question was, how often do we see individuals coming in with drug-seeking behaviors asking for controlled substances, but they're not getting them for themselves, they're getting it for other people. And unfortunately, we see that often. And the way that you identify that is that, well, I think it's pretty common sense, is that when I decline a prescription or when I say I don't think this is in your best interest, they don't get mad, somebody else gets mad. So again, I work with pregnant women. This happened. I had a pregnant lady that was prescribed Suboxone. She came into every appointment with her mother. There was a lot of aberrancy with respect to her utilization of the Suboxone. She was getting early refills. It just was not a good clinical scenario. And I shared with her, I said, based on everything that's happened over the last couple months, I feel we need to end this therapy and transition you to something else. And her mom went nuts. Her mom, yeah, I haven't been called that many bad words in a long time. So, yeah, she got very upset. So what we did in that situation was we actually had to have her leave the room. So she was so irate, and I told her, I said, I'm not feeling safe with you right now. You need to probably go out in the waiting room and cool down a little bit. And afterwards, the daughter said, I'm so sorry. I said, that's okay. And I said, what's going on there? Okay? And she didn't say anything. Oh, she's just very upset. And that's all she said. So she didn't want to talk about it. And again, so I didn't. So you have to decide, How far am I going to push this? You can try and elicit that kind of a history. Obviously, if that's going on, it puts me in a very uncomfortable position because now I'm likely providing narcotics to somebody who is obtaining them illegally. But kind of assessing that and proving that can be somewhat challenging. But if you have enough proof that it's going on and you can get it through drug testing, then you basically tell the patient is that, I can't prescribe this to you. And again, the way you do that, so if you get a drug screen and it shows, let's say she's prescribed oxycodone, the oxycodone isn't in her urine. Okay, so now I have evidence you're not taking it. I don't say you're giving it to your mom. I just say, this just shows me you're not taking it. And if you're not taking it, you don't need it, so I'm not going to give it to you. Again, I'm not casting blame. I'm not saying you're doing something wrong. I'm saying, well, the drug screen shows you're not taking it, so I guess you don't need it. So, hey, that's just one less med you have to take. Great. Okay? I think there was another point I wanted to make. Let me see here. Oh, so going off of the slides here, so do you continue to prescribe the oxycodone and the Xanax? So I put that in there. So let's say that this individual did come back and he was adamantly denying that he had a substance use problem, and he's asking me to continue to prescribe the oxycodone and the Xanax. At that point, I would not, because there have been so many, he did not go through to see the addiction specialist that I wanted him to go see. He did not proceed with the hair test, which I wanted him to get. So at that point, I'm not discharging him, he's discharging me. So many people kind of flip that and they say, oh, you're discharging him from your practice. And I say, no, I'm not. He's telling me he doesn't want to work with me. Okay? So if something like that's going on, then we would no longer provide that. And then the next step would be is that we would give him referrals to counseling. What we do in the clinic is we strike while the iron's hot. If I'm suspecting somebody has a problem and they're actually starting to convey that to me in the office, I refer them to counseling that day, that afternoon. And I have them call the treatment center with me or with one of our nurses in the room. So it goes something like this. I say, you know what, you've made a big leap here today. I understand this is a problem for you. We need to get you into treatment. Let's do that right now. And they say, well, just give me the phone number. Well, I'm going to give you the phone number. We're going to do that, but I'd really like you to call right now. Because I think when you get onto the parking lot, I think your motivation is going to be a little less. So it's important to kind of get them in the moment, have them call right there. In some instances, we try to get them into treatment that day if a program has an opening. There have been instances where I referred people to out-of-state programs. And there was one gentleman he was a healthcare provider. He was a radiologist working in the state of Michigan, was struggling with a severe alcohol use disorder, and I suggested he go down to a treatment center that's down in Atlanta that's known as Talbot, which does very good work with healthcare providers. And he said, well, when do you want me to go? I said, well, I want you to go today. I'm going to call them right now, see if they have a bed open, and I want you to go directly to the airport. Sometimes you have to do that because delay can mean significant problems. So referring them in the moment can be exceptionally helpful, and it can kind of it can get them where they need to be. Okay? So we're just going to quickly go over some of the conclusions, and then we'll end. So the first thing that I'd like to impress upon you is that opioid use disorders can be challenging to diagnose, and especially cases where prescription opiates are involved. Evidence-based assessments and evidence-based screening tools and assessments can identify at-risk patients, but they do not confirm or rule out an opiate use disorder. Okay, these are done to identify at-risk patients. In some cases, you need to obtain collateral source of information, utilize specialized drug testing, and scrutinize the prescription monitoring report to the best of your ability. Establishing trust and cultivating a clinical environment is paramount. This is what you really need to do. You need to establish a trusting relationship with the patient. And again, at least in the practice that we have, I'm not out to set up a diagnosis at the first visit. And if I have this person that's sitting across from me with their arms folded and doesn't want to talk to me, it's all right. We'll get through the first assessment. I'll get some background information from him. If he doesn't want to talk to me at that assessment, that's okay. I'll just ask him. I'll say, well, I really appreciate you coming in today. I think we got a lot done. I learned a little bit about you. I'd like to have you come in again in a couple weeks. We can do this again. So again, what you're doing is you're establishing a relationship where it's non-threatening and where he has an opportunity to talk to you. Because chances are, if this individual is struggling with an opiate use disorder or any other kind of addiction, there's something he's struggling with too. This isn't just the compulsive utilization of oxycodone that's causing significant detriments in his life. There's other things going on. If I can get him to talk about that, then we're on the right track. So this, in some instances, it's a long-lasting, evolving process, okay? All right. So those are just some clinical pearls for you. What I would encourage you guys to do, if you can download the slides or if you can obtain them in some other way, try implementing some of the questions that are on that slides. I think you will find them useful. Again, it's not meant to definitively diagnose a problem. It's meant to give you information and data and to help you form further relationships in counseling with the patient. Because if you have stuff to talk about with them, then you're making progress. So I want to thank you guys for inviting me down here to Louisiana. I've really enjoyed it, and I'm happy to entertain any questions at this point if there are any. Yes? Right.
Et cetera. How much, and this is, I guess, kind of a CYA question, is how much liability if you did not prescribe and he had withdrawal symptoms from the benzos and had an adverse event from the benzos, what kind of liability would that be?
That's a fantastic question. So the question was, and I apologize for not addressing this in more detail when the question came up. So if you remember in the case that I brought up, I said that the individual is not going to comply with my recommendations, is that he's essentially, self-discharging from my practice because he's not abiding with what I'm currently recommending. So the question here in front is, what kind of liability would I have to that? So let me talk about that just for a couple minutes, and I think I do have a couple minutes. The first thing is this, is that there's a couple reasons why you don't want to prescribe. So if somebody is struggling with an opiate use disorder, yes, it is a significant liability for you to prescribe opiates to that person. So if I'm identifying within my medical record that I'm suspecting this person has got an opiate addiction, and the next line I'm saying, continue oxycodone 120 milligrams daily, there's a concern there. So what I do to mitigate that risk, I basically identify in the chart is that I'm concerned this is going on. I've asked for a consultation. I've asked for specialized drug testing. I've asked to meet with his wife separately. He isn't agreeing to any of that. Although I cannot confirm the diagnosis, I can't rule it out either. Therefore, I have to stop prescribing. The liability with that in an ordinarily healthy individual, the physical risks of opioid withdrawal are pretty minimal. Now, that's in a healthy person. So he may have some nausea, vomiting. He may feel like he has the flu. I think we all know what the symptoms of what opiate withdrawal are. And I tell him that. And I can certainly provide, what I'll do is that I will provide medicines to mitigate that withdrawal. So you want to provide supportive care, ibuprofen, encourage him to have fluids. You can suggest the utilization of clonidine. Again, I can kind of help him through this if that's something he wants. And then what we do is we have our nursing staff, sit down with him and let him know when it is that he needs to go to the emergency room, like if he starts to dehydrate because of vomiting. But generally, it's not a problem. With the benzodiazepines, though, that's different. So benzodiazepines, the physical effects of withdrawal from benzodiazepines, as we know, they can be cardiovascular in nature. They can be, you can have a seizure, which can be significantly problematic, especially if you're driving or if you fall, you hit your head, you get a hematoma. This can cause bad things. So it's very careful, and what I do with them is that I disclose that to them. So I say, you're on Xanax. You need to be medically withdrawn from this. My recommendation to you is that you need to go into an inpatient facility and you need to be medically withdrawn from this because these are the risks, Mr. So-and-so. The risks are this. You can have elevated blood pressure, tachycardia, A, B, and C. You're at risk for seizures. Based on what I'm seeing, I do not think this medication is safe for you, and I think you need to be medically withdrawn from this, okay? If he doesn't want to do that, I have a couple options. I can provide him with a quick taper of phenobarbital. Now, there's risks associated with that because phenobarbital in excess can be lethal, whereas benzodiazepines cannot. But nonetheless, phenobarbital is very long-acting. It is self-tapering, and it's typically provides better symptomatic relief for people that are withdrawing from benzos. So the first option is to do nothing, is to say that I've told you about the risk, I've told you what can happen, I told you need to go to medical inpatient, you are refusing that, so you're not giving me any options here. That does have some liability associated with it. The next thing to do is to provide him with a short-term phenobarbital prescription for over like 5 days. The next thing to do is to give him a weaning dose of Klonopin, a long-acting opiate, either Klonopin or Valium. So writing like a 7 to 10 day taper, okay? And then I write specifically on this is how you take it. So if he's on 2 milligrams BID of Xanax, that's 4 milligrams of Xanax. So let's say give him like 20 milligrams of diazepam, wean him over 7 to 10 days. That's the other thing that you can do. So there's many ways to do it. There isn't one thing, so the opiates are relatively easy. The benzos become a little bit challenging, and there's many ways to implement this, and it really depends on the nature of your practice, and it also depends on your nature, the relationship you have with the patient, right? Because keep in mind, anything in this situation, there is not one right answer. Because I can give you an answer, and I can give you a list of 10 things that are gonna go wrong with that. So, but as long as you're being thoughtful, you're being judicious, and you're identifying what your intent is, then you should be fine. I hope that answered the question. Any other questions? No? Okay, thank you guys so much.